All right, I believe we are live. Good afternoon. Today is February 18th, Friday. This is United Medical Accountable Care Organization. My name is Kamal Arkan. As usual, we are going to go through some updates from COVID-19, and we do have our guest speakers today from the state of Delaware. And we are going to start with the vaccine updates first. Sean, we can actually give the updates on the vaccine, where we are right now.
Yeah, for sure. For an interesting time, we can definitely go ahead and get started with our COVID updates. Overall, case-wise, the U.S. had a decrease in the weekly average the previous week. So as last Friday, we had around 234,000 cases. This week, we are down to around 155, so pretty significant drop right there as we see that curve continuing to kind of really dramatically drop downward in our cases. As far as the vaccines go, the U.S. is up another 4 million this week in overall vaccines being administered. So that is continuing with that slow uptrend over time as we go into the spring months here. And then in regards to the U.S. versus Delaware comparison, we have the nation as a whole is now up over 214 million people being fully vaccinated, and of those 92.2 million have actually received their booster. And then in the side margin, as always, we have Delaware's comparison percentage-wise. So it seems that we're increasing on average about 0.2% in each of those columns. Kind of over the last couple of weeks, we've seen that. So overall, again, our population being over the age of 65 is still the highest rate of vaccination, again, because of the initial availability of the vaccines being made available to the elderly population and those at higher risk. So overall, steadily increasing, and that trend is going up and the cases are going down. So good signs.
Well, those are all good signs. I know last night at our provider meeting, we are meeting every week, every Thursday night. So hospitalization numbers are down to low 100s. I think it was the critical cases were 10 or 11 total for the state of Delaware. So I think we are getting better, but still we have to watch out what may be coming back. So there are still some unknowns that we are going to be dealing with. So today, I want to make sure that we don't spend too much time before. Normally, we do go through almost like 10-15 minutes in the beginning. So I do want to bring Mary Jo Condon as our guest speaker. So she's already on the screen. So Mary Jo, welcome to our session. How are you doing?
No, thanks for having me. I'm doing well. It's good to be here.
So, well, we are having these live sessions every week. So usually the format is, we started doing this for a long time. Now the format every week, one week we do clinical, and the other week we try to bring someone from the state or one of our state officials, so they come and give us updates. So, and then as an accountable care organization, I thought it would be important to have you and actually understand what your office does, what you do for Delaware, and just to better have a better idea what may be coming through our way. So if you can actually maybe introduce yourself first, and then I have a couple of questions, and then we'll just go from there.
Sure, that sounds great. So good afternoon, everyone. My name is Mary Jo Condon. I serve as director of the Office of Value-Based Healthcare Delivery for the state of Delaware. The office sits within the Department of Insurance. And I'm also a senior consultant with Friedman Healthcare. So essentially in that capacity as a consultant, I also serve as director of the office and have been serving as director of the office since its inception. We worked, and supported the department in sort of standing up the office. And the office was first put into place in 2019 by the General Assembly. And essentially what the General Assembly said is, we need an office within the Department of Insurance that is going to be tasked with really giving us a better understanding of healthcare cost trends and specifically how we can invest more in primary care. And so that was the initial purpose of the office. The charge of the office has expanded a little bit in the last session of the General Assembly, and we can talk a little bit about more about that in a few minutes. But that was sort of the initial purpose of the office. And so when we came into being, the first thing that we did was really sort of dig into the data and try to get a better understanding of what currently is happening in healthcare costs in Delaware. And what's probably not a surprise to you or to any of your partners is that we found that Delaware primary care providers were not really being paid enough to sort of fully capitalize on the opportunity of primary care. And so we made some recommendations, and those recommendations included increasing the amount that we spend on primary care in Delaware, sort of reallocating some of the what have been typically price increases to for non-professional services, taking a portion of that price increase and reallocating it to primary care. And then also supporting the state to moving towards more value-based payment, which I think ACOs are so well positioned to support the state in doing. So that was sort of our initial recommendations. And last session, the General Assembly took those recommendations, kind of refined them a bit, and put them into statute. And so we can talk a little bit more about that statute too in a few minutes.
So I think one of the questions that we have with the triple aim and everything that we are trying to do from the primary care side, as you know, you are familiar with our organization.
Yep.
So the triple aim is one of the main goal for all of us. And now with the accountable care organization, we actually took that to a different level. And now, with the changes that's coming through your office, how would that impact the ACOs? There are right now 4 ACOs in the state of Delaware. 2 of them are hospital-based and 2 of them are private ACOs. How would this impact us? What should we expect in terms of the ACO?
Sure. So the first thing I think you can expect is that for your primary care providers, which are sort of who are moving along that care transformation continuum, who are able to offer an expanded scope of primary care services. And I think many of your practices are already sort of starting or have moved along that continuum. You're going to see higher reimbursements. So one of the pieces of the statute is to increase primary care reimbursement to a defined percentage of total cost of care. And the other thing that the statute does, and specifically that the draft regulations that we released do, is also say that if you are providing services, primary care services, that would be paid for by Medicare on a non-fee-for-service basis, but are not currently paid for on a fee-for-service basis or a non-fee-for-service basis by commercial insurers, they need to start paying you for those services. So if you're doing uncompensated care management services that you don't have a revenue stream for, those sorts of things, basically the carriers need to expand their non-fee-for-service payments. And they need to meet certain requirements in terms of the percent of the total healthcare dollar that goes to primary care. So that's what's sort of happening on the primary care side. The other piece, and actually before I move on, one thing I want to make really clear about that is that, the office has been explicit that increased reimbursement needs to come as part of sort of a statewide movement towards advanced primary care. And so you may wonder, well, what do you mean by that? Well, the Primary Care Reform Collaborative has started to think about what that includes. over time, we don't expect this day one. This is sort of an evolution for all of us, but over time, it's going to include things like integrated behavioral health. It's going to include things like having folks who are on the primary care team who are really dedicated to supporting patients and connecting with social services, including things like care management, including things like 24/7 access to some type of care delivery that's not the emergency room. So what we're really hoping is that this increased investment helps to fund a lot of the initiatives, the care delivery initiatives that you all have probably been wanting to do for some time, but haven't really had the reimbursement streams to make those financially feasible. The other piece that it does, and that's right, that's that PCP shortage. We'll talk about that as well. And the other piece that it does is, as you all maybe know, Delaware is a state that has one of the highest rates of per capita participation in MSSP programs, in CMS sort of accountable care MSSP programs.
So
we have not.
People are listening. So MSSP is the accountable care for Medicare.
That's right, exactly. Accountable care for Medicare. Thank you. And we haven't seen that on the commercial side, right? So on the Medicare side, lots of Delaware providers through your ACO, through the 3 other ACOs, are participating in Medicare programs that aim to improve the quality of care, achieve that triple aim that you had up a minute ago, and do so while also hoping to reduce costs, right? Yep, which is part of that triple aim. And they've participated in Medicare programs to really sort of support them in achieving the triple aim, which is the Medicare Shared Savings Program. On the commercial side, what we've heard from providers is we would love to have programs like that with the commercial carriers, but we haven't really been able to agree on terms. And what we hear from the carriers, we'd love to have programs like that with the providers, but we haven't really been able to agree on terms. And so what the statute and what the regulations do is essentially help give people some guidance and guardrails around how to get to terms that everybody can hopefully agree on.
So I think I gave the spoiler a little bit this is our new format, so I have to do some of the stuff on my own. So I think one of the big issue is the PCP, primary care shortage. Now, from our side, I've been in the medical field for almost 22 years. And I probably, as a person, from the personal side, I probably did the most number of interviews to hire a physician in the state of Delaware. Now, the state of Delaware also have a J1 program for those regional areas where you don't have enough providers, so you can actually hire foreign graduates, and they come and serve for about 3 years minimum. And I probably did about 30 J1 applications in the last 20 years. And many people don't really understand what these are. But with the hospitalist groups, with the primary care groups and other specialists, if I tell you if it's more than 800 people, providers that I interviewed, that wouldn't be an exaggeration. So, but the shortage is still there. So I wasn't able to hire enough people. So
yeah.
How is this affecting, do you have any plans on addressing the primary care shortage? I know with the physician assistants and the nurse practitioners that we are utilizing, that helps. And then there's also the claim base, which some people may not really understand. If you can kind of talk about those so that we have a better understanding.
Sure. So the first thing I'll say is that I think there's a lot of consensus that in Delaware, primary care providers have not been paid enough to attract new primary care providers to the market, or in some case, retain the primary care providers that we have. And there was a study that was done by the Department of Health in social services not long ago that really sort of documented this, and it's also referred to in a report that we put out at the office a couple of years ago. The piece that I would really emphasize here is that if we remain solely focused on using additional dollars to attract only new MDs and DOs and even NPs and PAs, so physicians, nurse practitioners, physician assistants, I think we're not going to be successful. So I think what we really need to do is a couple of things. One is we need to pay primary care providers more, right? We're not paying primary care providers enough. Two, we need to compensate primary care teams for providing a full range of primary care services. And we need to make clear that if we want to achieve the triple aim, that will not occur through, 9 to 5 office visits, right? It needs to, with a physician or even with a nurse practitioner. What we really need is a primary care team that represents the full complement of expertise and experience that a variety of providers can bring. And we need to, allow the primary care physician and also the nurse practitioner and physician assistant to really practice at the top of their license, right? And so in some cases, that's going to include seeing patients. But in other cases, it's going to include coaching other members of the primary care team on how they can support patients. It's going to include looking at data and seeing patients as a population, identifying those that are most in need of the expertise of a physician, and also thinking about those that would benefit from care by other members of the care team. That could be a nurse practitioner, that could be a community health worker, that could be a behavioral health clinician, a wide variety of skill sets on that primary care team, because primary care providers can't do it all alone. They need help. We don't have enough of them to do it all alone. And I would argue that beyond not having enough of them, it's not really the best use of their time or expertise. And so really thinking about how we use them more strategically, but also paying primary care in a fair and sustainable way.
So I'm sure our primary cares are happy to hear that the state is working on better payments. Now, I think the other issue with the payment is one problem, but I think the representation of the primary cares in the state committees in some of these decision-making departments. Hospitals are getting more louder voices than we do. And I was really hoping that ACO would be a way to fix those representation issues so that ACO can represent all of our private practices, which are mainly primary care. Anything that is on the way to maybe address those representation issues from your side?
Sure. So a couple of suggestions I would make. One is we released draft regulations on Senate Bill 120 just a few weeks ago. We received public comment. I don't believe we received any public comment directly from an ACO. So providing public comment on things is one way to have your voice heard. We do have revised regulations that'll be coming out on March 1st. So would encourage you to take a look at those and feel free to give us your thoughts on them through the public comment process. The other thing I would say is that the Primary Care Reform Collaborative is in the process of recruiting members for its work groups. And so I would reach out to them. We don't oversee that process. We're a separate agency, but we work very collaboratively with them. And I would reach out to them and volunteer your time and your folks' time and let them know that you're here to provide input because I know that they're looking for folks to join those work groups.
Yeah, the unrelated to this, working with our primary care very closely, sometimes we get direct messages, text messages. Even now I'm getting messages. So one of the issues there's these services available that sometimes Medicare makes these and Medicaid makes these services available, but there's really no clear way of knowing who's going to provide these services. And primary care offices, they're already overwhelmed with so much that they do. And like today, so if I may just read you one of my messages.
Sure.
So this is, is Medicare now paying for the bathroom rehab, which like the message was like this. I had to kind of Google it right away because sometimes you're in the middle of something and you don't know what this is talking about. So there is a service that actually some Medicare plans can pay for certain renovations for the patient's bathrooms. And patient hears this, and then they the first thing that they come is their PCP. They don't go to their cardiologist, and then they don't ask their cardiologist, write me a letter to qualify me for this. They come to their PCP. So I think hearing from you that PCP payments increase on the PCP payment is the one of the main focus is actually really helpful. So my next question for you is, I think part of what you are doing is ensuring the compliance and price transparency in terms of the hospitals and the ambulatory payment classifications for outpatient facilities. So what do we have in place today in terms of pricing? Patients, do they even know that this is available to them? And I try to explain these in our live sessions, but how are we going to ensure the compliance and the transparency on the pricing?
Sure. So I think there's a couple of questions built in there. So let me kind of try to break them down, and then at the end, you can let me know what I missed. But the first question I heard was around hospital price transparency. And so I think what you may be referring to there is that there's a federal executive order that is requiring hospitals to post their prices. Is that, yeah?
And they start doing that already. There are some websites, like Medicare websites that make that available, but it's not very straightforward. So like if I'm just always thinking about my parents, if they were to use Medicare, my dad is 81, mom is 71, how would they use that complex system? And it's not easy. But you're exactly right. That's what I'm referring to.
Yes, absolutely. So a couple of points on that. So one is, just to clarify, that is a federal requirement, and so we do not have oversight over it. However, that being said, because we do have a responsibility as part of our state mandate to produce information and reports around pricing, healthcare pricing in Delaware, we did include in our most recent report a section on compliance, essentially put in a table that showed which hospitals were complying, which ones were not, and how they were complying or not complying. So one issue is basic compliance. Did you put the information up on your website, right? And I'll tell you, what we find is that hospitals, not only in Delaware, but nationally, are generally not in compliance, not in full compliance with that requirement. And so the federal government is doing a variety of things to consider how they can make them in more compliance. One thing you might not be aware of is the fines for noncompliance are very low. And so when you have low fines for noncompliance, it's really hard to get people to comply, especially when it's something that they don't want to do.
So actually, the compliance is, well, more than 85% of the hospitals are not complying with the rule.
That's right. That's what I said, is that people are not complying with it. And I think one of the reasons why people are not complying is, one, they don't want people to know their prices, but two, the fine is low. So there's not a lot of incentive to comply. The next piece that you raise is, really around how are we going to make these sites better for consumers to be able to use them.
Right.
And, I don't know if so over the last probably 10 or 15 years, there's been what I think has been a positive evolution in the Medicare hospital compare site. It's still not good, but it's better. And it's gotten easier for consumers to use along the way. I personally have used the nursing home compare site several times to try to find nursing home care for relatives. And I think that site has gotten better. I hope that over time, the price transparency sites get better too, but you're absolutely right that they are really not there right now. I think the real purpose of having this data out there right now is for purchasers, large employers, health plans, health policy folks to be able to see the variation in price and sort of act as early adopters and information disseminators and get that information out to others. But the first is sort of just basic exposure.
So the exposure, sometimes like when the hospital systems are so strong, it doesn't work. So our numbers, what's being paid to us is public for fee-for-service for the private practice for Medicare is public. So, but when it comes to hospital, the billing is very complicated. Many people really don't understand how it works. And I actually did, in one of our sessions, I did the comparisons, and even for us, even knowing the background, it's a lot of stuff going on there. So being complex is one thing, but not complying with this is another thing. I think perhaps there has to be some enforcement, like if you're not penalized. Like today, when I was driving back here, there was a police officer right behind me, and then I slowed down. So I wasn't going to slow down otherwise, right? So when we see the enforcement, then we make changes in our behavior. So, and I think the hospitals do make those changes. They do respond better when there is a significant consequences. Otherwise, they really don't change. Now, do you see any role from your office for the anti-competitive behavior, addressing the anti-competitive behavior? Now, this is even more problematic for our state because we are small and there's only so many players. There are only so many players. Does your office have any role to address some of those issues?
Sure. So the first thing I would say is that, the work that we've done so far on, for example, market share and anti-competitive behavior in the state has been to publish data. So if you go to our reports, you'll see that we talk a lot about market concentration. One of the reports that we published, we published in early 2021 was really had a lot of discussion around the amount of market share that hospitals in the state control. And one of the things that we found was that hospitals in the state of Delaware can control more than, and when I say control, they essentially have, in some cases, more than 80% of the discharges for their core service area, right? So every time hospitals have to publish something each year called a community benefit report. And in that report, they define what they see as their core service area, who they're really there to serve. And so what we did was we took those zip codes or that they defined as their core service area. And we said, okay, how many total discharges occur for individuals who live in those zip codes in a year? And then we said, and what percent of those discharges were from a specific hospital? And what we found is that in some cases, that's upwards of 80%. And, nationally, we have a problem with hospital consolidation. It's not just in Delaware. But we did find that the problem is intense in Delaware. And it's certainly something that we felt the state and its stakeholders deserve to understand. And so dedicated a section of that report. We also talked about consolidation on the health insurer side, right? So we have a dominant, health insurer in Delaware, and we talked about that as well. Our job as an agency or as an office when it comes to this work is really to put the data out there and to inform the General Assembly and other policymakers about what's occurring. And so, we have made that data available. There's more data to come that looks at not only market share, but also what may be price and the impact of price or the impact of market share on price. Also, additional data to come that shares a little bit of information on the level of reserves that hospitals in the state are holding. So to sort of answer your question most directly, I think we do have a role in the sense that our role is to provide data on market trends in the state of Delaware, and that can include information on market share, on prices, et cetera.
Well, this last question is related to the private practice again. So, I'm not going to be too humble about what I have done for private practices in Delaware. Because of me, I was able to do keep so many private practices, providers in the private offices. Well, this means the open market. There's we are able to compete. We are able to actually provide this the cost of the care at a lower price. So if we lose the private practices, the cost is going to be going up for everyone. And we are fighting. This is a fight for every day. Me, my office, my team, my providers, we are fighting with the system because we are under the for-profit label, which is total nonsense, because we are providing services for Medicare, Medicaid, and commercial insurances. But I was in a meeting with Congresswoman last Monday discussing some of the healthcare related issues. And one issue was we have like 25 patients who are homeless and they have Medicaid. So this is a problem, right? So this is just because we are for profit doesn't mean that we don't provide care. So I just want to make sure that and I think that's what I'm hearing from you, which is very helpful. The value for primary care, for private practices should be highlighted and should be protected, because we don't have the big dollars behind us supporting us. As you know, like nonprofit is just a label. All of our hospital systems except one, they're all big profit centers, and they're very costly for our people. When I do case conferences every day with our team, well, we look at these, one of the United Health dual plan. So these are Medicare patients with, they have Medicare, Medicaid eligibility, and it's not about just providing care anymore for that group of patients. It's understanding their social situation, understanding their day-to-day, what they go through, and what we can do. Like the food insecurity is one, transportation is another one, and we have to take care of all those problems. Everything comes back to the primary care at the end of the day. So we do whatever we can from our side, and we are also trying to support our society by these sessions, and hopefully people are benefiting from this. And I really appreciate you joining us and answering our questions. Did you want to add anything before we close the session?
No, just the only thing I would add is that I think the issues that you just brought up are so important. And, the state has made it clear that it wants to provide more support for primary care and primary care providers. I think the state has also made it clear that those types of services are important. For example, helping to connect patients who are experiencing food insecurity. But also that, the primary care physician can't be the person who's responsible for all of that, because that's just too much to ask any one person to do, right? And so really thinking about how we can best deploy care teams to ensure that patients receive the care that they need, that their social drivers of health are addressed, as well as their clinical drivers of health, as well as their behavioral health issues, and really trying to all pull together to think about how we can do this in an effective and sustainable way. So thank you so much for having me.
Well, thank you again. So I'm sure we'll see you soon. Until next time, please stay safe, and we'll see you soon.
All right, take you.
All right, so my next speaker is from the revenue cycle management side. So Carlos.
Hey, Kamal, can you see me? Hear me?
Yeah, I can hear you loud and clear. How are you doing?
I'm good. How are you doing?
Good, good. So we are going to do the reporting. So what I'll do is I'll actually open PowerPoint for this section, as part of the presentation. So you let me know how this is.
Sounds good. And
introduce yourself briefly.
of course, thanks. First of all, thanks for having me here, Kamal. As you mentioned, my name is Carlos Meinhardt, and I'm one of the senior client managers for the RCM team here at United Medical. And today I'll be reviewing some of the reporting capabilities that our practice management system, which is SPM, currently has, and how our team uses this to run some of the day-to-day tasks and also to provide feedback to our clients. So we can just start with the PowerPoint, and I'll briefly go through it. So SPM offers a variety of reports, and depending on, come on, if you want to stay on the previous slide, depending on the needs of that the provider office has. However, today we just wanted to focus on the three types of reports that we use the most at United Medical, which are the daily reporting, the monthly reporting, and the scheduling. We also want to introduce QuickBase, which is an application development platform that we use here on a daily basis to do pretty much everything, from tracking our daily productivity in all of our departments to managing a variety of projects. Kamal, I went back in the previous meeting that we had, the previous live session, and reviewed some of my notes, and it was interesting to find that we didn't have QuickBase when we first started. And as we started working with more clients and had more complex processes with all the different specialties that we deal with, it was important that we had a business database that we could use to manage all of this information. So I found that pretty interesting. Like I said, we gathered the information from the PN system and uploaded it to QuickBase so that we can compile all of the financial reports for our clients. I'm going to start with the daily reporting, Kamal. This transaction detail report is one of the reports that is mostly used by our RCM team. We run this report on a daily basis to track productivity, whether it is corrections from our RCM team, AR team, total payments posted by our payment posting department, or coding entries made by our coding team. Also, provider offices, they can use this report to track the charges, payments, and adjustments based on the needs that they have. And as you can see, it's customizable. It's pretty customizable. You can select a specific user if you want, or again, depends on the provider needs. The report on the right side, Kamal, it is the procedure analysis report, which we use on a month-to-month basis, pretty much. This report includes CPT counts, charges, and payments and adjustments, and we upload this report into QuickBase on a monthly basis. If you want to go to the next slide, Kamal, this report is the scheduling report. This report is used to track the appointments from our provider offices. It can also be customized based on the provider needs. And at least I started getting more familiar with this report once the COVID-19 pandemic hit. We started to keep track of the practices that had a decrease in the number of their appointments. And it helped us identify which practices were staying a little bit behind in the total number of appointments, which then allowed us to push the telemedicine use for those practices a little bit more so that they wouldn't stay behind and their revenues wouldn't be affected as much. Now, with the quick-based reporting, we have, as some of you may know, we have 23 different specialties that we have currently as clients. And we understand that each specialty requires a unique setup. Therefore, we have to adapt the way that we do the reporting for those clients. One example that I can give you is a nephrologist, they may want to see a report for how many dialysis codes were billed on a monthly basis, which is something that a cardiologist does not need because they don't do any dialysis. So we have adapted our reporting based on the specialty and the reports that we provide to those clients.
And you guys are updating those categories almost every month.
Correct.
In case if there are any new procedure codes as part of that specialty. That's
correct, yes. So Kamal, if you want to go to the next slide. This is our quick-based reporting, the denial reporting that we use, and this is based on the preventable type. These are the denial reports, which show us a correction that our team made during the previous 3 months. These corrections are broken down by preventable type, and this stem from the source of correction that is being entered by our team. These are unique categories that Kamal, you established several years, a few years ago. And the idea of the report is to tell us, for us to be able to tell the client how their claims are being processed, what's delaying the claim payment, and if there's something that could be prevented from the client side, we wanna point that out so that the client can fix their any issues that may be causing that delay.
Yeah, I think one of the main things that we want to highlight is when we started versus what we have today. In time, we made a lot of updates based on the need. If there's a need, we are able to make adjustments and we are able to adapt these changes, and that's part of the system that we are able to develop. And I think
correct.
We're able to comfortably talk about this, so because you are part of that system.
Correct. And Kamal, now that you mentioned that, one of those updates that we created in the last couple of years is the provider specialty is now included in the reports, so we can compare similar type of groups. That's something that we didn't have before, and it makes it more meaningful to clients because they often want to see how they're comparing to a peer or to a similar group. I think you say that all the time. We don't want to compare apples to oranges, right? So, yes. Now, the next report is the main category by client specific. This report provides a breakdown of based on the denial origin. Check-in versus checkout. Check-in is typically any insurance type of denials that our team is correcting. Let's say incorrect insurance was billed for a patient, an inactive insurance was billed, or incorrect ID was entered for that insurance that was billed. We make those corrections. We resubmit the claims to the insurance, and we provide the feedback at the end of the month to the client so that they know what's being done incorrectly. On the checkout side, it's typically if a CPT code was billed incorrectly or a modifier was missed by the checkout staff, we usually also include it in the report and review it with them on a monthly basis. So now, Kamal, this report is a little more detailed report and summarizes the total corrections per denial code that our team had in the previous 3 months. So it just is a little more detailed breakdown of each of the corrections that we made and what the client can correct on their end. I have a couple more slides, Kamal. We just also wanted to show a little bit of the financial reporting, and
I think it's just a little bit slow. That's why. Are you able to see it?
Yeah, I can see it. Okay. This is a report that shows a breakdown of the charges, payments, and adjustments for one specific client during the year 2021 and 2022. It's one of the first reports that we have on our end of month reports, and it's very useful for the clients just to see where they stand in terms of productivity and the payments that they're receiving. So
Pretty much, Carlos, these reports, I'm going to actually get to some of the others. So these are the reports that our team are sending to the providers on a monthly basis. So our providers, our clients are receiving these reports every month in the same format. If there are any changes that's made, that may be the only thing that they see, but the rest of them are going to be, the main thing is consistency and the systematic, like everything is happening every month in the same way, so then they can make these comparisons. So I know we have a couple other slides, and I may actually ask you to come back for this.
of course.
Somehow we are still struggling with the time management. Every time I feel like Sean can come up. Actually, every time I feel like we don't have enough topic. Carlos, you can stay.
I'll stay. Okay.
So every time I feel like we don't have enough topic, apparently we have too much because 3 p.m. Bariatric
Creeping up on us. Yep.
So now, since Carlos is also from a background, similar background in terms of the country, well, different countries, but
yeah,
where he's from and where I'm from, we do have similar issues, and we are kind of used to the picture that you see here. But one thing that I want us to kind of really understand, when we were preparing for these sessions, we do say a lot of stuff in between different topics. And when I was explaining this to Sean, I said, okay, we need to make our point very clear with the image. So, because when you see something is coming, and then when people are not listening, this is, well, it's scary, number one. Number two, it's coming. Now, Carlos, from his Venezuela background, he's used to this graph. From my Turkey background, I'm used to this graph. I'm slightly older than these guys, but not more than a couple of years. So the problem is now this is becoming the norm. So Sean is not used to this. So now he's going to get used to this because it's coming. I don't want to scare anyone. I just want people to prepare. So why the national debt is over 30 trillion? The inflation numbers are, every month is a record-breaking numbers. And it's coming. So Sean actually prepped a lot of good slides for us to discuss, and I don't want to rush them through. And what we'll do is next week we have the clinical guest, Dr. Rhoneise, saying on the non-surgical bariatric weight loss approach. She's part of United Medical Clinic, but we'll probably spend the rest of the time for this topic with Sean, everything that you prepped for. So I will make sure that we can spend enough time, but just kind of give a little, maybe a couple spoiler here is, let me just see if I can bring this up. I thought I saved it, but I cannot find it now. So just the gas prices in the United States compared to 6 months ago, 7 months ago, is 50% more. Many people don't understand this. When inflation is 7.5%, that's the new record, but that doesn't mean much because what's impacting our life may be average in that 7.5%, but where we spend the money is going to be in more expensive line items like the gas and like the energy and other stuff. And this is happening everywhere. So I want you to go to the weekend with this picture in your head. And as young people you guys are, you don't spend all of your money and you make some preparation for future. And Sean, what we will do is, since you spend a lot of time on these with me, we will spend proper amount of time for this next week. But the global economic recession is going to be our one of our topics, as well as the Neuralink updates that we are going to have. So we have 5 minutes to Bariatric Friday. So we'll say goodbye now, but we'll be back next week. Thank you so much, guys.